Yeah, maybe everyone should be mandated to have their specialty on their license plate and probably help their road rage. Well, great, thank you for joining us. I'm here with really one of the preeminent leaders in aortic disease, Dr. Eric Isselbacher, who's the co-director of the Aortic Center at Massachusetts General Hospital, associate professor of medicine at Harvard Medical School. Thank you again for joining us today. Before we get started, I think that you mentioned that you've really made it clear to anyone driving in the Fruit Street area of your specialty and your interest. Maybe you could share that little story for us.
Well, my son is always industrious, and he went online and discovered that the license plate Aorta in Massachusetts had not been claimed by anybody else. I'd never thought to look, so he claimed it for me and gave it to me as a gift, which I thought was wonderful, and proudly drove around with Aorta as my license plate, but quickly discovered that as I approached Mass General Hospital, every other doctor approaching the hospital would see my car and immediately know who it was. So I realized that I had to be a little better behaved, not that I wasn't, but driving into work, very polite, let everybody cut in front of me because they know exactly who I am. So some pros to having that license plate, definitely some cons.
Yeah, maybe everyone should be mandated to have their specialty on their license plate and probably help their road rage in
I
Boston a
think
little
so.
bit. So perfect. Well, you're obviously you're a cardiologist. You're not a surgeon, and you're leading this aortic center, helping to lead this aortic center. How did you get interested in aortic disease? When you were training.
When I was a medical resident in the emergency room, a patient came in with symptoms that seemed typical of aortic dissection, and I know I don't look that old, but this was back in the days when we would do an aortogram, a catheter-based aortogram to diagnose dissection. So it was actually a big deal to get the test. So we were able to get the vascular radiologist to perform the test, and they sent the patient back down to the ED saying there was no dissection. And I was left trying to figure out, well, what's going on with the patient? Everything suggests it's a dissection, but it's not. And it turned out to be an intramural hematoma, which we then diagnosed on a CAT scan in the ED after that. And I thought to myself, what's going on with this disease? We don't know how to diagnose it. We can get a test that's supposed to be the gold standard, and it said it was negative. So I started to investigate the diagnosis of aortic dissection and the imaging modalities, and that led to us writing a review in the New England Journal about it. And then everything kind of rolled forward from there. I kept asking questions, wanting to answer them. And so from residency through fellowship and onward, I was interested in aortic disease. So had it not been for that one patient, I might be an electrophysiologist now. I don't know. Then the other thing that happened, which was key, was that um, we saw the challenges of managing some of these patients. Uh, the aorta was kind of the orphan part of the vascular system. No one really owned it. So cardiac surgeons were involved, vascular surgeons were involved, vascular medicine specialists were involved, imagers were involved, but no one really owned the aortic patient. And so we kept having to bring people together to try to decide what the best way was to manage a given patient. And we realized there's got to be a better way to do this.
Mhm.
And so with two of my colleagues back in 1999, we launched the MGH Thoracic Aortic Center, which then really became my clinical home ever since.
Mhm. That's wonderful. Thank you. And so, what does that look like today? What are the different specialties involved in the aortic center? What's the path of patients who are coming to the institute? That sort of thing.
Well, so the primary three clinical participants are cardiology, cardiac surgery, and vascular surgery. But certainly cardiac imaging plays an important role. They're not involved in the clinical discussions about a given patient, but clearly their expertise in performing the best imaging for a given clinical scenario is key. We've got interventional cardiology involved, um, aortic genetics involved, in rheumatology as well, because so many of the patients have rheumatologic disorders underlying it.
That's wonderful. And do you guys have any sort of interdisciplinary conferences or imaging review or things along those lines?
We do. We have a regular clinical teaching conference where all the specialists and trainees come together, and that's been going on since we founded it. We originally tried to have routine clinical meetings to discuss patients, but the fact is, given the number of patients with acute issues, we really now do it on the fly, depending on which physicians are involved. We get together um, around an individual patient rather than a team meeting because there are so many patients with different providers.
Okay. And you mentioned trainees, and obviously it's essential that our current trainees get exposure to this and are comfortable with this. So what's the role of exposure to aortic disease for the cardiovascular fellows at your institute?
Well, you've struck a nerve there because things have really changed over the years. It used to be that uh, acute type B aortic dissections went to the cardiac intensive care unit. They were managed by cardiologists, and the cardiac fellows were involved in all of those patients. But once stent grafting became a more routine treatment for type B dissection and other endovascular techniques, and once it became clear you really needed the vascular surgeons involved on an ongoing basis, we ended up moving those patients from the CCU to the surgical ICU, where vascular surgery would have a stronger presence. I think that was a good move clinically for the patients. The problem is it cut the cardiology fellows out of it. And the second problem, for better for worse, is that I end up seeing most of these patients along with one of my colleagues, Amy Spooner. And so the fellows who are on a clinical service, regular consult service, don't get exposed to these patients. So good for the patients that they've got aortic experts seeing them, but again, it limits the exposure of our cardiology fellows, which is a real problem that we've been trying to solve. When fellows are on elective, encouraging them to see some of these patients with me or Amy, but they don't have much free time. So I feel like many of our fellows are getting through a 4-year fellowship without much exposure at all to either acute or chronic aortic disease.
Yeah, as our fields, whether it's cardiology or vascular medicine, as they get broader and more disease processes and subspecialties, it's really challenging to maintain enough clinical exposure to everything without extending the training, of course. So we've been talking about multidisciplinary care. That's obviously a really important part of caring for these patients. You were also the chair of the recent aortic guidelines. Can you talk a little bit about the emphasis of multidisciplinary care in that document as well?
Yeah, I have to say, the team we put together to write the guidelines was really phenomenal. I expected a bit more friction among the different specialties and among some of the individuals, but actually it was really very seamless and I think highlighted the degree to which teamwork is now an accepted part, in fact, a necessary part of caring for these patients. And we emphasize that in the guidelines because it is important. There's so much overlap between what the cardiac surgeons do and the vascular surgeons do, what the cardiologist does and the cardiac surgeon does, that you've really got to manage these patients together. Someone with an acute type 1 dissection with some vascular compromise, maybe radiographic malperfusion, but not clinical malperfusion or mild clinical malperfusion. Do you go to the OR and fix the ascending aorta? Do you address the malperfusion first? And whichever you do, being ready to do Part B really requires a multidisciplinary effort if we're going to take good care of the patient. So rather than saying you're it and your patient, or I'm it, it's my patient, we view it as we're all in this team together. We've all got to take care of the patient. So I think it will always be a multidisciplinary disease, and the collaboration has been incredibly effective, and I think everybody benefits from it.
So you mentioned, helping to found this aortic center back in 1999. So you've witnessed really an incredible transformation of the field, whether it be in terms of genetics, stent grafting, those sorts of things. What do you think are really the big developments that we're looking forward to in the next, say, 5 years?
Yeah, I have to say it's pretty stunning as I look back to see how the field has changed, how much more aware people are of aortic disease and acute aortic disease, how much better we are at diagnosing it, how much better we are at acting quickly to address the problems, transfer patients, etc. Looking forward, I think that we've really only scratched the surface from a genetic standpoint. Even when we know that the aneurysm is familial, we only can identify a gene 20% of the time. So there are so many genes out there that we have yet to identify, and the pathways by which those genes mediate aortic disease we've yet to identify. So I think there's much work to be done, and when we do accomplish that, I think it will change the way we look at every patient and really individualize risk and care. The second thing, I think we have to get beyond the aortic diameter as the determinant of everything. It is the best thing we have, and we've got to go with it for right now, but clearly there's much more than that that determines a patient's risk. And whether that's wall stress or wall thickness, we've got to find better ways to characterize the phenotype. And still to this day, we can't really determine how thick an aortic wall is until we're in the OR looking at it with all of our imaging modalities. It's amazing to me that we haven't done better than that. So I'm hoping that with better phenotyping, genotyping, et cetera, we'll be able to better define individual patient risk, because I think that's what's going to decide how we can more effectively intervene in a timely fashion to prevent adverse events.
Perfect, great. So we've talked about multidisciplinary care within the cardiovascular space, but of course many of our patients with aortic disease, their first point of contact is not an aortic specialist. Whether it's primary care, emergency medicine, or some other specialty, that's really their first point of contact. So what do you think is important in terms of incorporating awareness or training in these other spheres?
One of the things that really is interesting is that most people diagnosed with aortic disease no one is suspicious of it. They stumble upon the diagnosis when they order an imaging study for some other reason, an echo for palpitations, a CAT scan for a nodule. So it's usually a primary care doctor or someone else like an emergency room physician who first makes the diagnosis. Then the question is what to do about that, and it's important for those people to realize that this can be a heritable condition, so the patient should have his or her first-degree relatives screened for it. Yes, it may not require intervention, but that doesn't mean that someone else in the family may not be affected. For people who haven't had their aortic aneurysm detected incidentally, if you have a patient with a bicuspid valve, you've got to make sure you know if their ascending aorta is dilated or not. If you have a patient who has a relative with an enlarged aorta, you've got to screen that patient for aortic disease. If you have a patient whose father died of sudden death at age 45, says he died of a big MI, but really he clutched his chest and fell over, that could have been an acute aortic syndrome. That person probably should be screened. So understanding the fact that aortic disease doesn't present itself readily, and that if you're not thinking about it, you may not pick it up, that's an important message for primary care doctors.
Yeah. So I'm sure you and your colleagues are doing plenty of education and lectures and things like that to kind of raise awareness of this disease.
We are, and I'm happy to see that some of the internal medicine courses now include thoracic aortic disease because it's important to get that message out. The second thing is that while we have aortic programs, the fact is if your 65-year-old patient has a 4.1 centimeter aorta, that doesn't mean she needs to be seen or followed in an aortic center. The primary care doctor can take care of that. Screen the first-degree relatives, treat the patient with appropriate medical therapy to get the blood pressure to goal, and then perform surveillance imaging. And with all of that, that's a problem that can be taken care of by the primary care doctor, whether in a tertiary medical center or in the community. It's easier for the patient. It's easier on the healthcare system, so not everybody needs to be referred in. We have a system at MGH called e-consults, where a primary care doctor can find a dilated aorta, send an e-consult, which is basically a summary of what's going on in the clinical question, and then we write back and say, yes, the aorta is 4.1 centimeter, would repeat surveillance imaging on the following schedule. We see you're treating with beta blockers and the blood pressure is at goal, recommend screening first-degree relatives, make some other recommendations about lifestyle and things like that. And essentially, we've done a consult with 2 paragraphs. The patient doesn't have to come in for an independent visit. It doesn't overload our system. It's a great way that everybody wins. So I think trying to make it okay for some of these patients with mildly dilated aortas to be taken care of in the community will be a good way to help manage these patients more broadly.
Yeah, I think that's great. I mean, obviously, we want to empower primary care doctors to continue providing care for the patients they have relationships with. Most of our patients don't live near these academic, aortic centers, so that's really a great idea. Well, great. Well, thank you again for joining us. It's really been a pleasure to talk, and hopefully we can do this again in the future.
My pleasure. Thank you so much.
Of course, thank you.